Hello, and welcome to this discussion on considerations for the CARE Act eligibility, in which we'll discuss some initial, ongoing, and complex cases for determining CARE eligibility. So I wanted to point out a few resources. We won't be going over in detail the eligibility criteria, although we'll reference some of them. But we do have some resources if you need a bit more information about each of the eligibility criteria for CARE. So we have the eligibility fact sheet, also a training, and then we also have a brief and a training on a diagnosis that was recently made available for CARE participants. We also have a training and a brief on Senate Bill 27, which included a few updates to eligibility. And then we have an overview, a training resource, that's a tutorial for completing a CARE petition, which will highlight how you can demonstrate each different eligibility criteria. So for today's discussion, we'll really have two sections. So there's first an overview of CARE eligibility, just some high-level points, and then we'll be going to a live discussion that was held between a few different county representatives on some complex cases that they've received. So some goals is that by the end of this training session, you will have an increased ability to apply updated eligibility criteria to your work, approach CARE eligibility scenarios in practice, and then better be able to collaborate with peers to discuss some real world challenges. So today's discussion is led and facilitated by Dr. Deborah Rose and Rachel Johnson Yates from HMA. So now we're going to turn to that live discussion. And again, first we'll provide some background on eligibility, and then Dr. Rose will facilitate a live discussion.
Thank you so much. Hi, everyone, and thank you for choosing to spend your time with us today. My name is Deborah Rose. I'm a principal with Health Management Associates out of the New York office. I'm a psychologist by background and training, and I am pleased to join you as one of your moderators today. Looking forward to passing it over to my colleague, Rachel.
Thank you. Hi, I'm Rachel Johnson Yates. I am an associate principal with HMA. I've been with the agency for about 3.5 years. I'm a licensed mental health and addiction counselor, and really thankful just to be here with you today, and thankful to you all for joining and to our panelists for volunteering their time to help us learn about what they're doing in their counties. And so with that, we can go to the next slide. So today we are going to talk about, we're going to kind of start the session by offering an overview of eligibility in the CARE Act, including, as Patricia mentioned, some of the updated criteria. And so the first part of our time today will just be kind of a refresher and a reorientation to the eligibility criteria that will be inclusive of the most recent adjustments that have been made. And then the second part of our time together will be the part that probably will be of most value, where we're able to hear from our panelists from several counties who are here willing to share with us how they have been navigating eligibility within CARE. So with that, we can go to the next slide. Okay, so at a quick snapshot, CARE eligibility has to include all of the following of this first list. The person has to be a legal adult at age 18 or older. They have to be experiencing what is called a severe mental disorder that's defined in the California W&I codes. And they have to have also a diagnosis of bipolar 1 disorder with psychotic features, a schizophrenia spectrum disorder, or another psychotic disorder. It's important to note that this section does not include eligibility for psychotic disorders due to medical conditions, and a person that has a standalone substance use disorder without one of the other diagnoses that are mentioned before doesn't qualify for CARE just with the substance use disorder diagnosis alone. However, substance use and bipolar 1 with psychotic features, schizophrenia spectrum, or other psychotic disorders that are co-occurring may indicate that a person has the appropriate diagnostic combination to be eligible for CARE. The person has to not currently be clinically stabilized in ongoing voluntary treatment. Participation in CARE is considered to be the least restrictive alternative necessary to ensure that the person is likely to move toward ongoing recovery and stability, and that the person is likely to benefit from participation in care or from having a care plan or a care agreement. Now, some of these words might feel a little bit uh, amorphous in terms of how you navigate them in a court setting, and so that's part of what we'll talk about later in the panel. And then we have to have at least one of the following that's true: that the person is unlikely to survive safely in the community without supervision, and that the person's condition is substantially deteriorating. We also need to see as one of the two options here in this section, the person is in need of services and supports in order to prevent a relapse or a deterioration that would likely result in grave disability or serious harm to that person or others. Let's go ahead and go to the next slide, please. So we wanted to zoom in here for a moment, just because this is such an important addition to the care eligibility. So Senate Bill 27 added bipolar 1 disorder with psychotic features as an eligible diagnosis. And it's important to note that about 1.5% of adults in the US have a bipolar 1 diagnosis just in the past year. And 1.5%, when I first looked at this, I thought, like, oh, okay, that's a relatively small number. But then when you do the math, that's just shy of 5 million adults across the United States. So when you think about that in comparison to the population of California, we have a really large pool of people that perhaps could benefit from involvement in care. Next slide, please. So as we all know, a qualifying diagnosis is only part of the criteria, and it's not enough to by itself determine eligibility for care. And so the court has to determine if the other eligibility requirements are met. And so as we are thinking about the person in front of us, that we are trying to determine whether or not they meet eligibility for care, we have to ask ourselves whether or not they are experiencing a serious mental disorder, which is a disorder that's severe and persistent and significantly disrupting their daily life activities. It might be impairing their behavioral functioning to the extent that they aren't able to maintain their functioning, their housing, transportation, employment, et cetera, without ongoing supports and rehabilitation. And then we want to look at whether or not the person is clinically stabilized. And we'll zoom in more to this here in a minute. But a person's considered clinically stabilized in ongoing voluntary treatment only if both are met. One is that they're stable and not deteriorating, and two, that they're actively participating in voluntary treatment. So more to come in a moment on that. We also want to know whether care is the least restrictive alternative. And so that means that the care process is likely to offer a solution that provides necessary supports and interventions without having to resort to moving that person to a program with more restrictive measures like involuntary hospitalization or conservatorship. We also want to look at whether it's likely that the person will benefit from participation in care or a care agreement. And so this means that the services and supports that are part of care are likely to be the right intervention for this individual. The care process, as you know, is designed to help increase stability, improve the quality of life for folks, reduce the likelihood of crisis. And so using things like FSP or ACT. And so when we're looking at the person, we really want to evaluate, does a higher level of involvement with, or any level of involvement with this voluntary outpatient treatment have a chance of giving this person the support they need to help achieve stability and or recovery. We also want to see if their condition is deteriorating, and so that could mean a couple of things. One option is that they're, like we said, unlikely to survive safely in the community without supervision, and that their condition is actively deteriorating, which means that their symptoms are severe enough that they are struggling to meet their basic needs like food, shelter, medical care, etc. And also that the other option is that services and supports are needed to help prevent a relapse or further deterioration for the person that could lead to harm to them or the people around them. Next slide, please. So when we talk about a person that is not clinically stabilized in ongoing voluntary treatment, this can mean a couple of different things. So the person might be declining services consistently or intermittently, or maybe that their current treatment plan is not effective in stabilizing their condition, or they may just be kind of no-showing intermittently. So it may not be a formal process of declining services, but just that they aren't engaging. So care eligibility requires that the person is not clinically stabilized in ongoing voluntary treatment, like we've talked about. And so if a person is stabilized in involuntary treatments, in involuntary treatment, such as LPS conservatorship, they can't be considered stabilized in ongoing voluntary treatment. And so that's really important to note because care is intended to uh, offer an opportunity as a step down from LPS conservatorship as well. So it's really important when we're conceptualizing eligibility to make note and take note of whether or not the programming they're participating in is voluntary or involuntary, and whether or not that they are stable in that level of care. And it's important also to know that stability is not something that is all or nothing. It's not an on and off switch. And it's often very dynamic, right? So when we are dealing and working with and supporting people that have serious mental illness, what we know is that levels of stability really occur along a continuum, which often means that a person will have varying levels of stability in varying levels of their life at any point in their engagement, right? And so they may be a person, as an example, that is not interested in taking medication, but they're generally maintaining their housing, able to care for themselves, do their activities of daily living, and function relatively well in the community despite maybe experiencing some delusions. That person may go through periods of losing their housing or having trouble staying consistent with taking care of themselves, et cetera. And so it's really important that when we're thinking about care eligibility, we understand uh, how we're defining stability and that we are really intentionally applying that sort of definition and that understanding that it does vary along a person's lifespan to whether or not that they are stable in their outpatient or involuntary treatment orientation. So next slide, please. So on this slide, we are talking about how determining whether care provides the appropriate level of support involves assessing both the individual's clinical presentation and the level of structure that they need to maintain engagement in services. So in terms of the voluntary engagement, early on in the care process, county behavioral health begins by attempting voluntary engagement. If a person does participate in services without the need for court involvement, the case might be dismissed at that point because the additional structure of care and the additional accountability of care might not be necessary for that person to engage in voluntary treatment and maintain their own stability. But there are situations in which the care process is beneficial, even when someone is willing to engage. Sometimes we will see folks where the ongoing structure, the regular check-ins, coordinated treatment planning, outreach, the court hearings themselves are really, really helpful in helping people maintain their stability and helping them access the care that they need, avoiding disengagement. And in those circumstances, care actually might still be the appropriate level of support because it helps offer continuity and accountability that voluntary services alone may not provide. And so this is a really important nuance that just because a person says, yeah, okay, yeah, I'll go to treatment, and they are saying they will do so voluntarily, and sometimes even if they've started that, that doesn't necessarily warrant an immediate dismissal. In some instances, counties may decide to keep that person an active participant in care until we have really established that stability is feeling like it is likely to be ongoing and consistent. We also want to consider the acuity level. And so counties have encountered individuals who present with really significantly acute needs. people being discharged from state hospitals or transitioning out of the justice system. And in these cases, the question isn't just simply whether the person needs an additional intervention, but whether that level of structure offered by care is sufficient, and for how long do we think it will be sufficient. So someone might temporarily require higher levels of care, including crisis intervention, inpatient hospitalization, and also may still benefit from the ongoing involvement of the care team. So these sorts of acute episodes don't necessarily rule someone out of care. They might just highlight the importance of coordinating the approach to supporting and caring for that person over time. And so ultimately, when we are determining whether care provides the right level of support, it really involves evaluating that individual's current level of functioning, their history of engagement, the potential benefit of the structured oversight that care provides, and evaluating the likelihood that the care framework will strengthen the continuity of their care, has a likelihood of reducing their disengagement and helping promote their long-term stability. So lots of things to consider there. We'll go on to the next slide. So this next slide is really just intended to be an illustration that when we are operating, within the care landscape, we are always evaluating a person's eligibility. And so we can see here, there's a couple of red boxes on here where we are formally evaluating whether or not this person meets the eligibility criteria. But the eligibility criteria, of course, is always front and center. Now, it's important to note that the purpose of care is to help a person become more stable. So, it's really important that we structure our care approach so that when a person does begin to stabilize, we don't dismiss them immediately, that we make sure that stabilization is likely to be long-term, that we have a transition plan, that the supports that they have through care will be continued, transitioned, perhaps decreased in intensity, but that we have a really good plan in place to make sure that the transition away from care when the time comes does not feel too abrupt and is not likely to disrupt that person's pathway of recovery and or stability. Next slide, please. So here, just some ideas in action, and these are some more things that we will touch on today and in other sessions. So a lot of times these are some questions that we get. If a person is already engaged in services, like enrolled in outpatient treatment, are they still eligible for care? So what we know is that an individual who is participating in ongoing voluntary treatment might still be eligible for care if they're not stabilized and if they meet the other eligibility requirements. And when you're considering people who are already engaged in services, you will likely also need to consider their likelihood to benefit from care and whether or not care is the least restrictive option. We also get a lot of questions around whether substance use or a substance use disorder diagnosis disqualifies somebody from care. And so as we touched on earlier, a substance use disorder as a standalone diagnosis when considering eligibility is not enough to make that person eligible for care, but substance use disorder can absolutely be co-occurring with any other of the care eligible diagnoses. And it's really important that we find pathways to care for that person's co-occurring mental health and substance use needs because they are so interconnected. And then another question that we get is, how do you determine whether or not care provides the appropriate level of support? We're going to dive into this more in the panel, but just briefly, determining whether care is the right level of support is done by assessing whether voluntary services are sufficient or likely to be sufficient, and whether the structure, coordination, and ongoing outreach of care is likely to add that extra boost that will help them engage and receive maybe a higher level of benefit from voluntary services alone, even if that person is in a space where they're experiencing some higher level acuity. All right, and with that, we will go to the next slide. And from here, Dr. Rose, I will turn it over to you.
Thank you so much. And really appreciated what you were saying. There's a lot of questions that are coming in, so people are listening, Rachel. I'm going to remind folks that you can use the chat function because there is some activity that's going on here. So I think that we are going to kick us off with a poll. And so I'm going to ask Sarah if you could throw that in. Thank you very much. And we are going to take a moment, if you can please complete it. And I think it's a thoughtful question, so we can give it a moment and let people answer. Sarah, I cannot see what percentage that we are at, so when we creep up there, if you can please let me know. Okay, so for those of you who may be calling in and not seeing the screen, our questions were about common reasons for the dismissal of petitions that you've seen in your counties. The number one reason that people have reported on was that they cannot locate the respondent at 42%. So nearly half of the reasons here for dismissals has been that the person can't be found. Interestingly, the second one, which I'm really curious and to hear and would love to talk about it more here, is not meeting the diagnostic requirements. And so certainly that's one of the scenarios that we'd like to hear about. What are you doing with that individual if he or she has not met it? What if they didn't meet it prior to SB 27 and now you think they may meet eligibility determination? So we'll take a look at that. And then at 14%, needs a higher level of care that an outpatient setting can offer, followed by already voluntarily engaged and other. And I'm going to keep going. If Rachel, I'm going to ask if you could see if anybody's added anything to the reasons in the other, and just let me know, please.
Yeah, thank you. So it's been a couple of really interesting comments here. Most of the non-BHSD petitions have been dismissed due to the individuals remaining incarcerated during the investigation period, and then I think you saw already locating the respondents and then folks that are refusing that voluntary care. And then there's another note a little higher up around evaluating whether or not treatment is voluntary when they are released from jail. So a lot of complexities around incarceration, it looks like.
That's what it sounds like. And so the two additional things that we're hearing now are about the voluntary nature of it. And I did see that there was a question. So, hi, Kelsey, great question. If it's not answered by one of our panelists today, then we will circle back to you. So both voluntariness and if somebody's dismissed because they were incarcerated during the investigation. Thank you. Those are helpful. So with that, what I'd like to do is we have although we have lots of our counties joining, we have identified a few participants from some of our counties, and we've chatted about some of these questions with them. So I'm going to call on you and ask if you could very quickly introduce yourselves. Fresno, maybe Emma, could you please introduce Stacy and Katie from the Fresno team?
Absolutely. So my name is Emma Rasmussen. I'm one of the deputy directors here with the Department of Behavioral Health in Fresno. I have Stacy Van Bruggen, who's the division manager and oversees care. I also have Melissa Caldwell, who is our analyst, who is a unicorn and can do everything and is really our care expert. And then I also have Katie Wheaton, who is with our contracted provider, Dart West, who is over their clinical service.
Thanks, Emma. And Melissa has even been able to morph bodies today, so she can appear like another person. That's how good she is. I still can see you there, which means I can call on you, Melissa. You can't hide. Nick, please, from San Mateo, where are you?
Hi, Nick Zwordlane, San Mateo County BHRS. I'm the program specialist for care and AOT.
Thanks, Nick.
Sure.
And from Riverside.
Hello, I'm Karina Gustafson, and I am an administrator for several of our court programs, one of them being Care Court in Riverside County.
Thanks, Karina. And last but not least, Lavana.
Hello, Levana Adato. I'm the clinic administrator at Ventura County, and I manage Care Act Assist in our adult residential program.
Thank you. Again, thank you all for joining us today. We know that you are very, very busy overseeing programs, and so it's a real sacrifice to be here, and we appreciate it. So I'm going to start with the general group, and anybody can answer this that we're talking to. Certainly, Rachel has hinted at a bunch of them, and we've identified some in the Zoom poll. I'm wondering what other kind of maybe complex or particularly nuanced scenarios that your county has faced. Perhaps some things that we in other counties with less petitions might expect to anticipate down the road. What have you seen in yours?
I can jump in and say one that we had that I'm sure everybody has had. So it's not probably unique in any way, but an LPS referral to CARES that actually was still on LPS while we were doing our care court. So we had to have a lot of communication go through the conservator. Eventually, this individual did come off the LPS, but very recently we had this individual graduate from care, doing really, really well. So that's such a success story. So, and when we first received, it was our very first LPS respondent. So it was a lot of learning how to kind of manage that. So for us, it was a big challenge at first.
Thank you. And Karina, I'm going to let it go, but it poses so many other interesting follow-up questions that I would like to ask. So I'm going to parking lot that. It certainly represents working with a diverse community of people and what kind of resources I imagine that you're providing. But for today, I'm going to stay focused on that. And thank you. I'll reach out. So working with somebody who's coming off of LPS and what it would mean. What about others? Because what I'm hearing there a little bit, Karina, is kind of a hint or like, how do you think about how somebody might benefit from it? And that's particularly true when we're considering a step down from LPS to care. What about others? Lavana, I'm going to turn to you for a minute. Have there been any nuances in your county?
I definitely want to echo what Karina said because I think our challenges are around clients that are very high acuity to the point that we actually see them more as LPS and not CARE Act, but they were referred to CARE Act. I can give an example. We have a client that within 6 months was 5158 times, and he was referred to CARE Act. And I'm like, okay, is he really a CARE Act client? Does he need more stabilization before he comes to CARE Act? But we worked with him, we accepted him because, to see what we can do and what we can offer. So I think, the LPS clients are definitely a challenge. And the other challenge that we noticed is petitions that pass prima facie that not necessarily meet criteria. So this can be like parents that file a petition or law enforcement that passed a petition. And even when we try to justify to the judge why the client does not meet criteria, sometimes there are a lot of questions about that.
Okay, that's interesting. So in another scenario, people who pass, but perhaps you're not thinking, or after the 105, you're thinking perhaps the person does not meet eligibility. Okay. Other folks. Have there been scenarios that we haven't? Oh, please, Nick.
Sorry. Yeah, just with the multiple PES episodes and 5250s and all of that, like I think Care Court, from what I've seen, acts as an AOT, did the same. It kind of acts as like a resume builder, and I hate to put it like that for our clients. But if someone is involved in Care Court, they have a care agreement and they're still getting hospitalized, it's really useful information to tell a hospital, right? And to kind of help them understand, hey, this is a pretty high level of care, a lot of accountability, and it's still not working out for them. And oftentimes that can have hospitals take a client who might need that higher level of care a little more seriously. So just something I've found helpful. But as far as like the nuances, a big one that we've seen several times now is from the state hospitals. We're getting folks who not only have schizophrenia but also have dementia. And our FSP level care is not really appropriate for someone who has dementia. And so we don't drop somebody necessarily, but we've had to work with other agencies within the community, such as temporary conservatorship and forensic mental health, to make sure they evaluate the client, make that referral over to the TCON office to try to get folks, and even getting someone on a TCON who has dementia, it's not necessarily appropriate, but they can help kind of guide that person, that client to the right level of care. So that's been very challenging and honestly like quite heartbreaking too to see someone with dementia coming from a state hospital. It's just very tough. Yeah.
So what I'm hearing, a common theme that you're all saying is, unlike some other medical disciplines where you can run a test, many times we don't know, right? There's not a test if the person has schizophrenia or bipolar disorder. We're not getting a lab result back telling us yes or no. And so you're all talking about where somebody might sort of live in the seams between diagnoses, between treatment settings, between levels of care. Would you say that's a fair place of where these nuances are? And I'll ask Nick, Stacy, anybody who wants to. I see Emma nodding. So let's dive into that a little bit more. Um, let's talk about the likely to benefit and how you think about whether that individual, and equally how you can document in a petition and to a court if that person is likely to benefit from care. Nick, you said something earlier when we met. I'm wondering if you want to take that on.
Sure. I think what I said was, well, it's worth a shot. And then when asked to kind of elaborate on that, the by nature or like by the definition, like the criteria of what a care court client is someone who has schizophrenia or somewhere like on the psychotic disorder spectrum. They have that diagnosis, they're deteriorating. It's likely that they're not going to do well without further support. They're not clinically stabilized at ongoing treatment, etc. So if they were to enter into a care agreement, and that care agreement includes medication and therapy and case management, it is probably likely that someone will benefit from that. Is it likely that they're going to adhere to it? That's another story. Some yes, some no, but I think it is worth giving everybody a chance to kind of see if it does.
Thank you. Others.
I would
Other
like to
counties look.
add, oh, sorry. I would
Thank
like
you.
to
No,
add
I was
that
going to say, I see.
we definitely assess the level of motivation. So when we go face to face and interview the clients for the Care Act program to see if they meet criteria, there will be a few questions about their motivation level to participate in this program. Because, in Ventura County, the treatment team is an FSP team. We know that they will have to see their case manager, psychiatrist, therapist, at least 2 to 3 times a week. And that can be overwhelming for someone. So we definitely, when we introduce Care Act and we introduce FSP level modality, we also assess the level of motivation to participate in the services.
Thank you. Emma, you're nodding. Can I ask you if there's something?
No, I 100% agree with that because that's part of what, being able to engage in that level of care. It's part of the assessment when you are looking at where is the most appropriate place for them to go, what fits best for them. We look at, in Fresno County, kind of going back to some of our nuances that ties into, and I don't know if it's a nuance, it feels like a nuance for us, but that kind of ties into what we're saying is that we have a lot of our referrals, not a lot, but like many have been dismissed because of in just engaging or being willing to accept voluntary care. But then, we see them, which is great. But so that's one thing. And then just kind of like, I think following that, do they then come back? Are they then, are they engaging in that voluntary care? How is that going for them? So that's, I think, just more of what we're trying to just take a look at and track. Also, so that is just, I'm just agreeing with what Lavana is saying in terms of getting people to participate. And we have just, I think our contracted provider and our team can really probably attest to that, that we might have them engaged in one part and then that dies off, or we can't find them, or, how do you maintain that motivation? How do you help someone to maintain that motivation? I know our contracted provider does all that they can to try to incentivize and everything that they can to get a hold and keep them engaged. But it is challenging. Level of motivation is a challenge. So,
Well, and
So
oh, sorry,
please?
Deborah. Go, I just wanted to jump
Go
in
ahead,
with
Rachel.
a quick clarify or a quick additional question because Emma, what you said really triggered for me this idea of what does participation in services mean, right? And so we are working with a population in care that, we know are likely to have feelings of distrust. They may be struggling with some delusions. They may be struggling with some paranoia. They may be having co-occurring mental health and substance use disorders. They've trauma history, almost certainly, right? And so it's folks that have had and folks that have had varying levels of success and maybe additional trauma with medications, right? And so this is a complex, we're dealing with some folks that are very complex here that we're trying to support in a way that's respectful and person-centered. And I'd love to hear from the group a little bit more about, we're using the phrase participation in services, participation in treatment. And sometimes I think we can have a propensity to be like, that means medications and group twice a week and individual and case management, and you have to maintain housing. You have to, like, do you agree with all of that? Yes or no? No, then you're not eligible for care. But I think in practice, we are being much more responsive and progressive in terms of taking what we can get in terms of engagement and then using that as a launching point. So anyway, that was a long intro, but I'd love to hear what's your experience with varying levels of engagement or participation. Emma, I saw you come off mute, so if you want to.
yeah, well, I think that there is now, like, you have to meet all of these boxes. I mean, yes, there's certain I'm not talking about like diagnostically and
Sure.
It really is, when we talk about meeting people where they're at, it really is that. Like, sometimes someone's level of participation is different than someone else's, but it's still participation, and you take what you can get. And so, as it might be medication for one. Someone else might not be ready for medication, but it doesn't mean that they're not engaging. So I think it's just taking what people are able to give, but just continually making sure that we are, is this really the appropriate level for them? Do they need a higher level of care? Do they need more engagement? Do they need less? And just being willing to pivot to where they are, and making sure that our engagement is that we are. I mean, Care Act is all about engagement. It really is about just engaging in the way that they need you to, and it's a lot of engagement initially to get them to build their trust, to recognize that they have this long history of just multi-layered trauma, and what do they need from us. But I think getting outside of that box of this is what participation looks like. It really is what it varies in what it looks like. So
That's great. And I think, Karina, it may have been you. And if I am misremembering, please let me know. But I think you were sharing with me a few months ago, actually, about some folks that you had that maybe were housing only, or maybe just case management only initially, and then you're able to kind of use that as building blocks for engagement.
Yeah, we do that a lot. Like everybody else is saying, you meet them where they're at and what their needs are. It's always determined, in the very beginning when we do the assessment, to see what is this individual, what do they need, and what do they currently are getting. so that we can fill in the gaps of the things that they need. And they may not agree to get all that all at once, right? We do a lot of hand holding, and I'm sure everybody does that. Literally walking into the doctor's appointment with them, have an ROI signed so that we can be with them and make sure they can voice what their needs are. And so, because sometimes they cannot, but they may ask us to be there to, help them with that in the beginning. And we always obviously have the goal for them to be independent and to be able to handle things themselves. But in the beginning, it's, as I said, a lot of hand holding, definitely. And that has helped.
So one of the things that's interesting is listening to you all talk about your nuanced scenarios, is that they might feel nuanced in your counties, but in hearing you, you're all sort of experiencing a lot of similarities. So I think that there are less unique scenarios than we think about. Also hearing all of you, it's interesting, and I don't know what my question is. Rachel, I'm going to ask you to help me figure out what my question is about this, because I really am just thinking out loud. That it feels like, depending on who you're talking to within a county or across counties, we often hear, because they are voluntarily engaged, we're going to dismiss care. Or because they're not voluntarily engaging, we're going to dismiss care. And then sometimes we hear, because the person needs a higher level of services, we're going to dismiss care. So it's about, I think my question is, how do you in your county with your attorneys and courts and individuals determine what that sweet spot is, where you're able to say, we're able to articulate the person might benefit, and we're able to articulate that this is the right level of supports and services. And now, Rachel, I challenge you to help me figure out what that question was.
I think the question is, how are you defining the sweet spot, right? Of what, how do you define the sweet spot? Nick, I think you spoke to it a little bit earlier around, is it worth a shot for this person? But yeah, how are you defining that sweet spot? I think in a way that is understandable to the courts, right? Because we may
Right.
have a clinical impression that is difficult to articulate. So how are you articulating it? And then I'm just flagging in the chat. There's also a note about wanting to hear about experiences working with folks that are non-English speaking folks. So
Oh, thank you.
yeah. So just before I jump over to that, sorry to muddy the waters, where's the sweet spot between I'm dismissing because they are engaging in voluntary care or voluntary services, or I'm dismissing because they aren't willing to engage in voluntary services?
So I think one of the important things to remember is, what is the purpose of care?
Mhm.
What is the purpose? The purpose is to help people find treatment that they're willing and interested in engaging with, right? And so I'm also the division manager over our LPS programs here in Fresno.
Mhm.
And for me, their legal status on LPS and their legal status in the care process is one aspect of who they are and what we're trying to achieve. The goal is wellness. So how do I think we articulate that to the court is by not losing focus on what we're here to do. We're here to engage. We're here to give people a voice. If we provide people with something that they deem as useful and meaningful to their wellness, people will engage. I think it's important that we articulate that to the courts and to our partners, because those terms that were mentioned earlier, engagement, participation, and stability, are all subjective. So to whose standard, right? Does that mean you must take medication? Does that mean you must do this? And how is that outlined? So I think for me, it's less about I believe that if we do the clinical work and we're putting people first and advancing their interest in their care, then it's really easy to articulate that to the court. It's easy to show what that looks like and to show that participation and that willingness, because eventually they will be no longer on care. And the goal is to get them to accept voluntary care. So voluntary means something that I'm willing to do. So how do I use this process to do what I'm meant to do as a practitioner anyway? I don't know if that answers your question, but for me, the focus isn't necessarily on their legal status per se, because it's all the same goal, which is engagement and wellness. And I think that we need to really focus, in that area.
I love what you just said, Stacy. Thank you. And one of the rubs for all of us in our jobs in behavioral health and then working with courts is how we take that emotion and the sentiment that you express and we document it in a way that's digestible for the court. We're not necessarily seeing things the same way. So I think the question is then how do you, and I'm going to invite Nick back to this as well, and maybe let me ask Katie to also join us for this part of it, is that how do you document that in an evaluation or a petition? Both that it's the right level of care and care with a little c. It's the right level of services and supports for a person. It's the right least restrictive and the person's likely to benefit. So how do you put that to paper?
Well, I'll go ahead. For us, it's really, and I think I had said this earlier in our warm up, that like our clients have been through every level of treatment. A lot of them have, like from TCON to conservatorship to FSP, etc. So this is kind of a new avenue, a new way, a new vehicle for people to engage in treatment where they have the support of an attorney who can advocate for them and keep the providers accountable. BHRS, we hold our FSP contractor accountable, give the client a voice. And further in the agreement, like it's likely that if someone who has schizophrenia is taking medications and has added supports, meeting with a psychiatrist and therapist, and they adhere to that they're likely to improve. There is one nuance that's coming up for me that we're facing as a county, and I'm not sure how other counties, if they're experiencing it as much as we are, but we get a lot of referrals from 1370, like misdemeanor incompetent to stand trial folks. We've got a ton of them. And we have a lot of responsibility here because the way that we do it at least is that if they do enter into a care agreement, these clients are going to get released earlier. And so, this is a difficult task where someone in the community, it's much easier to create a care agreement that's going to meet the client where they're at. But when they're in jail and they're deteriorating and they're not taking medications, but they're agreeing to work with like a case manager maybe in the community, and they might consider shelter placement, um, that's it's a we've made some care agreements and where we let people out and they just end up reoffending because they're not really motivated, right? And so we're taking that responsibility seriously, and now we want to, kind of add into our care agreements. It might seem punitive, but to include that you got to take medications, you have to meet with the psychiatrist and a case manager, and if we can't come up with an agreement, then the judge can come up with a care plan. And that's like what we're thinking about. We haven't moved into that direction yet, but it's just putting the client and community at risk, honestly, if they're getting out early and they're unmedicated and not really willing to engage in treatment. So it's a tough one for us to navigate. We're talking about it as a team. So kind of exploring like, hey, what would that care plan look like? And is this why Care Court was designed this way, that if we can't come up with an agreement, then the judge orders a care plan. Anyway, sorry to throw that wrench in there, but
No, listen, I think it's a reasonable question that you and other counties and that we're all asking. It was a question that was raised in our chat earlier, so let me bring it back to that question of how are you considering maybe Levana or anybody else, quite frankly. I know that Fresno and I think Ventura are working with courts with jails as our other counties. How are you assessing the voluntary nature of a person's participation if they are in fact incarcerated while they're creating the agreement with you? Lavanda please.
Yeah. With Ventura County, we do get a lot of actually fist and missed referrals too. I think for us, it's not a one and done assessment with them. So we go to the jail to assess them to see if they meet criteria. But we also know that care court, right, with the initial phase, hearing of the merits, until we get to the case agreement, we have this idea of we go and visit the clients at least once a week in jail, right? First of all, it's building the engagement. We want to show them that we are caring about them and we are developing a plan for them after release. So for them to see a familiar face already from the care team is really important for us. So we do see them once a week. We do collaborate with jail people, also sheriffs, to see, if they notice any changes of behaviors and willingness to take medication in jail. I think that's a big factor for us too. And we have a forensic team embedded in jail. It's the criminal team, so we usually collaborate with them because they are the one that will refer us all the missed clients. So we also collaborate with them to see their impression of these clients and if they will be a good fit.
I have a question if that's okay. So yeah, we practice the same thing, right? We'll engage our clients and, not just in the courtroom, but actually go to the jail, talk to them, assess what their needs are and try to see what they want. I guess my question for other counties would be, have you been feeling the burden of, when you get that care agreement, they get released, pretty soon after. And have you been more cautious because of that fact? And have you tried to enter into a care plan because you might feel that clinically they need to be a little more stabilized in order to re-enter the community?
For Riverside County, I don't think we have actually entered into a care agreement until after they've been released. So we haven't done that while they are incarcerated. So once they are ready to come to court, we could have possibly drawn up the care agreement, but they haven't signed it yet. They would do that when they come to court and meet with their public defender.
With Ventura County, it's a little bit different. I think, like Nick is saying, there will be situations that will do a threefer, that the public defender and the clinician will go to jail because we are truly believe the client meets prima facie. We'll already sign a care agreement in jail and present it to the judge. But I believe that for these clients, they still have the 45-day rule, right? Like they need to be in jail for 45 days. So sometimes with our clients, they will be released before the 45 days that we will be able to sign the care agreement. Depends when they were referred to Care Act. Sometimes we'll be able to catch them in jail and do the care agreement in jail. I can tell you that in Ventura County, we don't have any care plans. Our public defenders actually does not support that. So I'm not sure that that was something that we will do. But we are truly striving towards care agreements with the clients and explaining to them the importance of it and following it.
If I can ask, I appreciate that. I am looking at the time. I did want to ask a follow-up question to all of you since it was put into the chat. As you are working with individuals, both within a jail or in your community and their families, it was asked how we might work with folks in assessing eligibility. I'm going to bring it to that specifically, or even looking at maybe petitions that have come from family members or others of how we look and work with individuals who English may not be their predominant language. Are there any considerations to take that into account when assessing eligibility?
I can add to that. I'm Katie from Fresno. For we just see it as the same as any other. However, we do bring somebody who speaks the same native tongue as they do to make sure that they understand everything. And then typically, if they sign up for an FSP, it's usually with our own program. So uh, they will already have been working with this person who, it's typically Spanish here, so that already speaks Spanish. Um, Other than that, I don't think we really do anything differently.
Thank you. So we have about 5 minutes left, and I'm going to make that 3 minutes so that we just reserve a couple too for a couple announcements. Are there any last minute thoughts or things I haven't asked? So quick summary, Rachel, I'll invite you in also. Things that I'm hearing is you're all facing some challenges, varying challenges about eligibility, diagnosis, location, if the person can be found or not, if the person is in a forensic setting or a carceral setting. And you're all using different, although well thought out approaches to try to manage those nuanced scenarios and convey them and document it appropriately with your courts and with your treatment partners. And so I just want to applaud that with all of the changes in care and with eligibility, that your counties have adapted and grown with it and are working on it together and now with each other, which is really lovely. So thank you.
And I would just highlight, I just really appreciate what you all have demonstrated around trying to really meet folks where they are and trying to give them a reasonable chance at the least restrictive environment possible, because it often does feel like a risk, right? When it's somebody that might be on that cusp, or when the answer or the clinical determination doesn't feel really cut and dry. That can feel really difficult to navigate. And what we've heard you all speak to is this real attempt to honor the dignity and the preferences and the autonomy of the person, and trying to meet them where they are, and then from there responding accordingly, as is appropriate. And I think that's something that really should be commended. And so thank you for sharing that with us.
Yeah, indeed. I am going to give it to Patricia. Last comment, though, is we have heard you and concerns and wanting to look at some of the issues of working with folks who are in the justice system. And so we are looking at opportunities for more training and technical assistance for counties for that down the line. So with that, thank you again, all. Sarah, thank you for keeping us honest. And I will turn it back.
That concludes this training and that live panel discussion. And again, the goal is that by the end of the session, you would have been better been able to apply those updated eligibility criteria in your work, approach care eligibility scenarios in practice, and then collaborate with peer counties. If you have any questions or you'd like to be connected with the county, or you have any follow-up scenarios that you'd like to discuss, please feel free to reach out to us at info@careact.org.